Sure,
So,
sure.
uh,
Sir,
all
we are live.
yeah.
Okay. So, good morning, respected faculty and dear delegates. Welcome to the last session of the Pediatric Nephrology Master E classes. Today's session will be taken by Dr. SUPRITA KALRA ma'am. She is at the base hospital, Delhi. And expert will be Dr. Shobha Sharma. Chairperson is Dr. Pankaj Hari. Dr. Pankaj Hari is head of the department at Department of Pediatrics, AIMS, and he is also a nephrologist, but he is not able to join right now. So we welcome him in his absentia. I request Dr. Neha to please start the session.
Thank you, sir. First of all, thank you to all the delegates who have been with us in this whole journey. So, this is the 12th and the last session of pediatric nephrology, and hoping that this session would have enriched your knowledge in pediatric nephrology. For further enhancement of your pediatric nephrology knowledge, we are having our annual conference Phoenix 4.0 Pediatric Nephrology that would be in Delhi on 17th and 18th October. We'll be sharing all the details in the group. And finally, I would like to thank Dr. Ajay sir because of his dedication. I think this has been possible. Dr. Dinesh, I think both of them have been the torch bearer in doing all these eNephro sessions, which have been wonderful. We have got a lot of good feedback from everybody for these sessions. Sir, a big congratulations to you and Dr. Dinesh for organizing these sessions for people who are staying very remote areas. And they
Thank
are
you, Dr. Neha, but the hard work is done by you.
so now we'll go for our last session, which is very, very interesting session because UTI is something which we face every now and then for our children. So to enrich our knowledge on UTI, we have an expert today with us. I would like to welcome Dr. Shobha Sharma. So Madam is Director, Professor and in charge Department of Pediatric Nephrology and Department of Pediatrics at VMCC and Safdarjung Hospital, Delhi. She has special interest in tubular disorders, acute kidney injury, kidney support therapy. She has multiple publications to her name. She has been a faculty at national and international conferences. Welcome, ma'am. I would like to welcome then our speaker for today, Lieutenant Colonel SUPRITA KALRA. Uh, Dr. KALRA is a very, very known person in pediatric nephrology. She has done her MD, DNB Pediatrics and Fellowship in Pediatric Nephrology from AIMS and also a fellowship from NUH Singapore. She is currently Professor Pediatrics and Pediatric Nephrologist at Base Hospital, Delhi Cant as well as Army College of Medical Sciences. She has multiple original articles as well as more than 50 publications in national and international journals. She has also written textbooks in various pediatric nephrology as well as ISPN courses. She has also been given World Kidney Day Award in 2017 and 21. So let's not waste time. We would like to hear from you, Dr. Suprita. So what we should do when a child has.
Thank you very much, Dr. Neha, for having me here and for the kind introduction. I will just start the presentation so that we can, be quickly on board. Yeah, just give me 1 second. So is my screen full this thing?
Screen is visible, but
Yes.
make it full screen, please.
Is it full screen now?
No, ma'am.
No.
Okay, just give me 1 second. Please check now.
Yes, ma'am. It's great.
Yes. So what I thought we'll concentrate today morning is UTI in children, guidelines and our interpretation of guidelines. Because guidelines are easily available, but sometimes we get confused as to how we should adapt and how we should interpret them for the best management of the patient that comes to us. So let's go to quickly for a small case. This is a 4-month-old male who had come with high-grade fever for 7 days. He had poor feeding, vomiting for 3 days, loose stool with 3 days, poor response to oral antibiotics. Usually, when a child comes like this, we, end up thinking of as a late onset sepsis. But it is important that we know what is the focus of the fever before starting antibiotics. And whenever children, young children, infants present with vague symptoms like this, it is important that before starting oral antibiotics, we send some blood investigations, cultures, and we also do an ultrasound of the abdomen. In this baby, it revealed bilateral hydroureteronephrosis. And as you can see this MCU, and we will come to it later, it is definitely not normal. And you can appreciate the bilateral high grade, grade 5 VUR on both sides. So we'll talk about this case later. It is just something that I want to leave you with. Another child, an older girl, 6-year-old. She had wet underpants noticed by mother despite mother trying to toilet train her very well as she had done for the other siblings. She was treated multiple times as UTI because she used to have some dysuria and perineal itching. Also treated as vaginal discharge. But when this child was evaluated completely, initially on examination, by the pediatrician, it was noticed one good pediatrician on examination after this vague history found that the perineum was actually excoriated and there was she was smelling of urine as if there was a urinary leak all the time. And organic causes of urinary incontinence in a child who is developmentally normal, as we know, would either be a neurogenic bladder and rarely a fistula. So when she was evaluated, she was found to have a rectovaginal fistula. So whenever we have such children who have vague symptoms, whether as infant or older children, we need to find out, is this UTI? So first of all, we should be thinking of a cause of fever or cause of urinary symptoms, and we try to figure out whether it is truly UTI or not. Why is this child having recurrent UTI? That is another concern. Then will this UTI cause scarring and other long-term adverse effects for the child in form of chronic kidney disease? If the child is having recurrent UTI, does the child merit prophylaxis with antibiotics? And whether, if this was VUR, is any surgery indicated? So all these are questions that we come to our mind, and also we need to understand them ourselves for the parents to know properly, for the parents to answer this, for us to be able to answer this to the parents. So let us try and go one by one. I'm not able to move to my next slide. Yeah. So like I said, so first thing will be to suspect UTI, confirm UTI, evaluate for cause before we are able to chart a management plan for any child. So Indian Society of Pediatric Nephrology has given the UTI guidelines initially first time in 2001, then it was revised in 2011, and finally in 2023, evidence-based clinical practice guidelines for management of urinary tract infection and primary vesicoureteric reflux were published. These guidelines are evidence-based and they give clear steps as to how to evaluate, how to confirm, and how to plan a good management plan for the patient. So first, to diagnose, how should you collect the sample? In small children, we know it can be slightly difficult, but especially in toilet-trained children, we can advise the mother on a clean catch. We should teach the mother or the parent a clean catch method, which essentially means that you ask the parent to clean the perineal area with soap and then make the child pass urine and take a clean midstream sample. In non-toilet trained stable children, clean catch can still be done with the mother trying to keep the child off the diaper, maybe breastfeeding or giving more water and trying to catch the sample as soon as the baby starts passing urine. If the infant is very sick, Then catheterization, quick in and out under strict asepsis, or suprapubic aspiration can be done. Another method that has been described for smaller infants is the quick wee method, where we first clean the penile area or the perineum, then we rub some cold ice or a ice bag just on the suprapubic area, and then try to collect as soon as the baby starts passing urine. So these have been recommended as a clinical practice point because there is not so much evidence on which method is the best. But it suffices to say that we have to ensure to collect a urine sample without contamination. Then how should we screen for UTI in a sick baby? Because we know that cultures can take some time. Urine routine examination and microscopy may not always be available. So it is recommended now, strong recommendation that urine should be screened with dipstick for leukocyte esterase and nitrite combination. Also, we must try to send a urine microscopy for bacteria as well as WBCs, that means leukocyturia, which is reported by many labs as pus cells in a freshly voided sample. If the sample can be seen in fresh within 1 to 2 hours, it can be transported to the lab at room temperature. But if it is going to take longer, then it is better to refrigerate the sample. Then, because the signs and symptoms, as we've already seen in these two cases, can be non-specific and early treatment is required. So these screening methods are very, very important. So leukocyte esterase will be positive whenever there are WBCs in the urine, and nitrite test will be positive whenever there is bacteria in the urine. So if let's look at this algorithm, very simple, gives us good guidelines on how to do things. So in a child who has fever without focus for more than 48 hours, especially if the baby is less than 2 years or there is risk factors or specific urinary symptoms, we must perform a urine examination and send for urine culture as well. This urine screening can be done. Perform the urine test and dipstick. The urine screening, as we said, can be with leukocyte esterase and nitrite, and urine routine microscopy and routine examination. So if the leukocyte esterase and nitrite are positive, we must start empirical antibiotics in young children and in children at risk, and while we await culture. Whereas if the child is less than 6 months, even if urine like leukocyte esterase or nitrite is negative, we start antibiotics. Why we do so, we'll come to it subsequently. But in a sick child, all these tests should not let us wait for starting the management. But if it is an older child, we can definitely wait for cultures. What are these risk factors? These risk factors are in a child who is already known to have recurrent UTI, who is already diagnosed with vesico-ureteric reflux, or who is known to have bladder bowel dysfunction. What is bladder bowel dysfunction? We just discussed. But remember, young children send samples, do urine dipstick, and start empirical antibiotics. Older children start empirical antibiotics only if dipstick is positive or if they have risk factors. If the culture is positive, and the cultures can be easily obtained from the lab in 48 hours, the dipsticks were also positive, we need to continue antibiotics. If the culture is negative, we must look for in this time alternate source of fever and also consider stopping antibiotics. Whenever leukocyte esterase and nitrite are negative in some cases, but the culture remains positive, then if the child is still clinically symptomatic, we start antibiotics. This side of the algorithm, the right side, is only, however, for older children more than 2 years and who have no risk factors. For children with risk factors and younger children, we prefer to do urgent screening and starting empirical antibiotics while we await cultures. Yeah. So coming to the next, I think there is some problem. I don't seem to be going to my next slide. Can I? Yeah. So but how do we confirm? As we have said, that dipstick and microscopy remains a screening method, whereas urine culture is the gold standard for confirmation. And whenever it shows significant growth of a single uropathogen, it is taken as positive. And it will be it will diagnose definitely for us a culture positive UTI. Now, what is this significant growth depends on how you have collected the urine sample. For a suprapubic aspiration, even 10 raised to power 3 colony forming units per ml is positive. For a catheterized sample, where you have introduced the catheter and taken sample from the catheter, definitely not from the urobag, then it is 10 to power 4. And when you take a clean cat sample, as we have just discussed, 10 to power 4 to 10 to power 5 colony forming units per ml is taken as culture positive. This number of more than 10 to power 5 was introduced long back for diagnosing UTI in pregnant females. And if we stick to this 10 to power 5 only, it was seen that the diagnosis may be missed almost in one-fourth of the children, especially infants and children who have non-E. coli uropathogens. They can have lower colony counts, and therefore this colony forming unit significance has been lowered to 10 to power 4 to 10 to power 5. And this is again a clinical practice point in this guideline. So now, when should we initiate therapy and how should we go about? So it has been recommended that therapy with antibiotics should be started as soon as possible, preferably within 48 to 72 hours of the onset of fever. That is why the screening and early sending of culture is so important. And it was found that children who remain febrile for more than 148 hours, that means multiple days, the scarring increases as it sorry, just give me a moment. If the fever remains, if a child with UTI remains febrile for more than 3 days, 72 hours, the occurrence of a scar, which can be seen later on TMSA, will be far more as compared to children who have been started with antibiotics in less than 72 hours. And this is probably one of the most significant factors which leads to scarring. So, and it is modifiable by early onset or early treatment with antibiotics. So this was how it was that in case of children who have remained febrile for more than 3 days, the prevalence of scar continues to increase. This was shown in a large study again published in JAMA Pediatrics by Nadir Sheikh et al. That children with fever beyond 72 hours, the risk factor for developing long-term renal scars doubles. And again, in a retrospective study, which took children who were enrolled in the large Revere and QT trials, and these were young children, they said that the median duration of fever with and without scarring differed from 72 hours in those children who had scars to 48 hours in those without scars. So definitely we have to start antibiotics within 72 hours, and as less than 48 hours is preferable because it is so much related to formation of scars later. But it does not mean that we do not confirm UTI. We just need to quickly do screening, send urine cultures, and then start antibiotics. Because wrongly labeling a child as urine UTI culture positive or UTI without sending cultures is also not correct. because then those children will not require these further evaluation or further management in form of surgery, etc. So which antibiotic should you choose? That is another important question. We must start with a third generation cephalosporin or co-amoxiclav as the initial empirical antibiotic therapy in children with suspected febrile UTI while we await the culture reports. For adolescent children with cystitis, a first generation cephalosporin like cephalexin or co-amoxiclav will also suffice. So pooled studies have shown, including large number of participants, have shown that there is actually no difference in persistence of bacteriuria or fever and recurrent UTI if we either choose third generation cephalosporin or coamoxiclav or even cotrimoxazole. However, cotrimoxazole is not recommended for treatment because these children continue to have clinical symptoms for longer time and that we know that maybe become a risk factor for scar. Now, what the antibiotics that we choose, should we give them oral or should we give them IV? So oral antibiotics are preferred. We do not need to admit these children for IV antibiotics, except if it is a small baby less than 2 months of age, severely ill patients with urosepsis, or patients who are so sick or who have so much vomiting that they cannot take oral antibiotics. And whenever we start IV antibiotics, especially in older children, we can switch them to oral after 3 to 4 days once they have stopped vomiting, once they are tolerating orally. And no difference was found between oral and IV antibiotics in terms of fever resolution, recurrence of UTI, or kidney damage seen on DMSA at 6 to 12 months. And this is another high evidence recommendation. So duration of antibiotics. So we have seen what antibiotics to give, how to give, and now how long to give. It is recommended that for children with cystitis, even 3 to 7 days of oral antibiotic therapy is enough. However, 7 to 10 days of therapy with appropriate antibiotics is preferred in children with acute symptomatic culture positive UTI. And longer therapy, more than 10 days, has not shown to be any additional benefit. So these are the various studies which brought out that how long should the antibiotics be given, and when they were compared, the RCTs, the systematic reviews compared the short versus standard course. So 7 to 10 days was found ideal in children with febrile UTI. In afebrile UTI, that means some symptoms of cystitis like dysuria in older children, we can definitely give them shorter courses of 2 to 5 days of oral antibiotics. So this is again a clinical practice point now that initial antibiotic therapy, whatever has been started, should only be changed based on clinical signs and symptoms, regardless of antibiotic sensitivity patterns obtained on culture. That means, let's say a 1-year-old child, if we have confirmed UTI, we have sent cultures for confirmation, but on dipstick, this febrile child had LE as well as nitrite positive. We think as suspected UTI, start antibiotics, IV maybe because child was sick, child was not tolerating, you have started IV ceftriaxone. Culture comes 48 hours to 72 hours later. By then, child is much better. Fever is almost just about low grade once or twice a day. Child is accepting orally. So you do not need to change this ceftriaxone even if the culture shows that the uropathogen was resistant. And why is this so? Because the culture only can comment on the lab growth, whereas in vivo, the antibiotic may be still sensitive, right? So here again in this algorithm, what we have already discussed, that adolescents with cystitis, short course oral antibiotics, febrile UTI or pyelonephritis in young infants less than 2 months, or in children with sepsis, renal angle tenderness, poor oral intake, vomiting, what was earlier labeled as complicated UTI, we should give them IV antibiotic for 3 to 4 days. If they respond to this, they can be shifted to oral antibiotics. And if there is no clinical response, we need to modify the antibiotics as per the urine culture. Imaging, we will just come to it in a minute. Now, what is asymptomatic bacteriuria? That means this child was well. The culture has been sent for some other reason, maybe pre-op or something. And if it shows positive urine culture of a single uropathogen in the absence of symptoms, it usually indicates a commensal. So it may be 10 to power 4 or 5, but it does not need to be treated. Please remember that if you have sent urine culture in a asymptomatic child and it comes positive, even if it is 10 to power 4 or 10 to power 5 in a clean catch, it does not require treatment. And actually, you should not have sent. So please do not send routine urine cultures. There is nothing called routine culture in asymptomatic children. So treat the symptoms, treat the child, not the lab report. So what are the risk factors for this renal scarring that we are so worried? Because we know that once the child develops a renal scar, then this can progress to CKD and also lead to other complications for the child like hypertension and proteinuria, which itself are risk factors for progressing to higher stages of CKD. So incidence of kidney scarring after one febrile UTI has been found to be about 15%, but if it becomes recurrent, it rises to almost 30%. And pooled analysis of large number of children from 0 to 18 years after first febrile UTI has shown that the risk factors will be if there is a high grade VUR, if the child had non-E. coli UTI, that means had Klebsiella, Pseudomonas or Proteus as UTI, if the child had very high fever or had abnormal ultrasound with some hydronephrosis, hydroureteronephrosis, or bladder abnormalities. So this is another large study published in 2015, which identified prospectively the risk factors for recurrent UTI and risk factors for scarring. And most of it said that high-grade VUR is the single most important UTI in young children who have been followed from 2 months to up to 72 months. So high-grade VUR is a very important risk factor for recurrent UTI and also a risk factor for scarring. So what should we do how should we evaluate these children after we have confirmed that it was UTI by cultures? What imaging should be done for these children? So to identify children at risk for recurrent UTI, renal scar or long-term damage, we need to have a plan for imaging. Who requires what imaging? So ultrasound scan should be definitely performed in the first episode of UTI in all children. It can be performed after the first episode or any time during the episode, specially recommended if the child is not improving within 48 hours of antibiotics, because we need to know that is there hydroureteronephrosis? Is this child maybe, having a VUR which was not diagnosed early? So if the patient is coming to you in a very sick state, sepsis, high-grade fever, culture is positive and you start IV antibiotics on screening, please try to do an early ultrasound because it may show you that there are underlying congenital anomalies or any bladder abnormality which was not diagnosed early. So when should we go recommend a micturating cystourethrogram, MCU, or what is called now as VCUG, voiding cystourethrogram? So it has been seen that it is the gold standard for diagnosis of VUR. But remember that VUR is significant only if it is high grade, and only less than 10% of VURs are actually high grade. The lesser grade, that means grade 1 to grade 3, where the reflux is only up to the ureter, not reaching the kidney, does not usually cause recurrent UTI and will not cause scarring of the kidney. So that means these do not require surgical intervention. So if we are not going to intervene, why subject the child to an MCU which requires catheterization? Also, so much radiation exposure, and sometimes even that catheterization can cause a UTI if it is not done in under strict asepsis. So, it is suggested that we perform MCU only if a child has UTI with non-E. coli uropathogen, less than 2-year-old child, or if the ultrasound is abnormal, or there is history of recurrent UTI. So whenever there is more than one culture positive UTI in a young child or a small child with non-E. coli uropathogen or a child with abnormal ultrasound scan, we still recommend that an MCU should be performed, taking care that it is done complete asepsis so that the catheterization for MCU should itself not cause a UTI. And also the timing of MCU is usually done when the child is completing or just completed the antibiotic therapy for UTI and is clinically stable for this imaging. That means can be sent to radiology, has already completed antibiotics for the UTI that he was sick with. And procedure should be performed keeping in mind that you give as little radiation exposure as possible, what the radiologists call as ALARA. When should you now refer a child with UTI for dimercaptosuccinic acid scan, that is the DMSA scan? So remember that while a DMSA scan has high sensitivity for picking up a UTI or a pyelonephritis, but specificity is poor. And when pyelonephritis is there, we do assume that it may be because of a high grade VUR, but it is not required. The first scan of DMSA that is recommended should be at least 4 to 6 months after a culture positive UTI to correctly identify kidney scarring in children with recurrent UTI or high grade VUR. It should not be done in the acute phase of febrile UTI. That means it is not a test to be used to diagnose pyelonephritis because the scars or whatever photopenic areas that you see on an acute phase DMSA will actually indicate infection. But we do not need DMSA to diagnose infection. To comment on the scar, whether the febrile UTI led to scarring, the DMSA has to be done bit later and it should be done after 4 to 6 months. Now, coming back to what is this bowel bladder dysfunction that I mentioned earlier. Now, this is a very important risk factor for children to get recurrent UTI, especially older children. Younger children who get UTI, we only suspect we have to rule out congenital anomalies of kidney and urinary tract, including VUR in both girls and boys, and posterior urethral valves in boys, which are the two most important conditions in young children. However, in older children who develop recurrent UTI, the urinary tract is likely to be normal in them, and this prevalence of lower urinary tract symptoms like dysuria, urgency, urge incontinence, daytime frequency, and sometimes even nighttime bedwetting with daytime frequency, along with constipation or encopresis, is what is called as bowel bladder dysfunction. And it was seen in children who have UTI that almost 40% of them have evidence of bowel bladder dysfunction. And in those who have VUR, the prevalence of bowel bladder dysfunction was close to 50%. So we should ask for these symptoms carefully and always evaluate for constipation because the risk of recurrent UTI becomes becomes double as in children with PBD as compared to those who have no bowel bladder dysfunction. So the identification of this entity which is causing the recurrent UTI in older children is very important to prevent further recurrent UTI and to prevent renal scarring. And if there is any degree of VUR, if the child has, that means even low grade of VUR 1 to 3, which I said clinically may not be significant, but if they have any degree of VUR along with BBD, then the risk for febrile UTIs and scarring becomes almost 60%. So all toilet trained children with UTI must be evaluated for bladder bowel dysfunction. Now, how should we evaluate? We should evaluate with history and we should evaluate for examination. And then there are few clinical scores, including Rome 4 and 5 criteria that help us in diagnosing functional constipation. So history-wise, I have already mentioned that ask for urinary incontinence, both daytime and in a toilet-trained child at night. Ask for symptoms of frequency, urgency, hesitancy, and voiding postponement. That means child is trying to do various maneuvers to hold the urine if he is or she is not able to use the washroom immediately or does not want to pass the urine. She feels that it will be either painful or she will have incontinence on the way to the washroom. Always ask for history of constipation and or encopresis. On examination, we can examine for fecoliths in the iliac fossa. Evaluate this child with 2-day voiding diary where we tell the parent to write the time when the child passes urine, time as well as urinary volume, and time as well as the volume of whatever the child is drinking. Water, milk, any juice, that should be documented with time and volume. So we want to see whether the child is able to hold enough urine as per the expected bladder capacity, and we want to document objectively whether child is having frequency and when and how did the child have incontinence. We also tell the parents to note the bowel movement, whether hard, pellety stools with or without blood in stools and with or without encopresis, that means fecal staining of undergarments over next 2 weeks. And then we evaluate these children for evidence of bladder bowel dysfunction with our friend investigation, radiological investigation, the ultrasound, which can tell you not only the kidney sizes, ureter, and the bladder, but also the transverse rectal diameter, which, if increased, is definite marker of constipation and can be seen in these children with PVD. And when the post-void residue in a ultrasound is more than 20 ml or more than 10% of the bladder capacity in 4 to 6 years children, we have to ask for this parameter. Otherwise, some of our radiology friends will miss it. But whenever a significant post-void residue is there, and whenever their bladder wall is thickened, and they must comment whether they saw it on empty bladder or full bladder, we must suspect BPD and go back to history and examination. So these three things for diagnosing bowel bladder dysfunction go hand in hand: history, examination, and ultrasound evaluation, and must be done in all children with recurrent UTI. So the imaging following UTI, first episode and again multiple episodes is always ultrasound. And also we assess these children for bowel bladder dysfunction. If the ultrasound is abnormal, we think of MCU. If there is high grade, we think of MCU only in presence of abnormal ultrasound, and we think of MCU if there is recurrent UTI. If the ultrasound is normal, we just follow up these children. We also consider MCU, like I have already mentioned, in children less than 2 years or children with recurrent UTI or non-E. coli UTI. So how should we prevent these UTIs? What can be done to prevent UTIs so that child does not have long-term effect in terms of renal scarring, progression of CKD, hypertension and proteinuria due to scarring? These children, if they have BBD, we should actively identify BBD and manage with urotherapy and manage the constipation. This will become an entirely different talk, so I will not focus on the management of UTI, of BBD, but it has definitely shown that it will prevent further UTI recurrence. Then should we give antibiotic prophylaxis? It is recommended in children with recurrent febrile UTI only if they have high grade UR. It is also recommended if the BBD is present along with any grade of UTI, right? And so this is what I have already mentioned, that recurrent febrile UTI and BBD, even if low grade VUR or even if no VUR is present, we must give them antibiotic prophylaxis. But it is not recommended in patients with normal urinary tract and absence of BBD, even if they have recurrent febrile UTI or one culture positive UTI. So young children with any grade of VUR, it is still recommended. Older children with recurrent febrile UTI, please go ahead, evaluate for BBD and give them antibiotic prophylaxis till the bowel bladder dysfunction can be completely resolved. However, in children with normal tract and no BBD, antibiotic prophylaxis is not recommended after a culture positive UTI. Now, only few children who have hydronephrosis will actually have primary VUR. So, a most common cause of antenatally detected hydronephrosis is actually a pelviureteric junction obstruction, especially if it is unilateral. So, we say that antibiotic prophylaxis is not recommended while you wait for further MCU or whatever imaging is required. So, do not, if the child has antenatally detected hydronephrosis, please follow that algorithm for management of hydronephrosis, but routine antibiotic prophylaxis is not recommended till you identify a VUR or if child has UTI. So this is a table which I will leave with you for which compares the analysis of guidelines, and all guidelines, if you see, they strongly recommend early screening with dipstick. They strongly recommend that we send urine cultures early and treatment with antibiotics orally. Only sick children should get IV antibiotics as discussed, and all patients, they all guidelines recommend that we do ultrasound. However, all guidelines are now saying that we do less, we do MCU in only few selected patients who are either getting recurrent febrile UTI or non-E. coli UTIs. And DMSA should only be done in children who have had recurrent UTI or who have been identified to have high grade VUR, and that too late stage DMSA, minimum 4 to 6 months after a positive UTI. So this is, I finish here. I think I have tried to sum up the guidelines and their interpretation for everything, for everyone, though not everything can be can be covered in one session. So I will stop here and I will hand over the screen to our experts.
Thank you, Dr. Suprita. It was a very comprehensive and inclusive talk on UTI. I think most of the queries have already been covered. I would like to just add on, rather re-emphasize some of the points for especially our postgraduates and residents, that it's very important that when we have a child of UTI, we don't have to just look at the, single thing that there is a urinary culture growth or a bacterial growth. We have to look the child as a whole, the cause of the UTI. So starting from the history, that if there is any bowel bladder dysfunction, as Dr. Suprita mentioned, has to be talked, or history has to be taken in depth. History of constipation may not be forthcoming if you ask directly to the parent or to the child. So if you ask about the history, how the actually stools are being, being passed daily, especially the consistency of the stool, frequency of the stool, that is really, it makes a change. And similarly, the voiding frequency and how's the type of the voiding, that is very important. The number of voids, the frequency of the voiding, any lower urinary tract symptoms along with that, any voiding postponement. Sometimes we need to sometimes take, voiding dysfunction is also a very, very important cause of UTI in children, which we often overlook. So those things has to be taken into consideration. Also, as Dr. Suprita mentioned, that culture is important for the confirmation, but we don't have to treat the culture. So if the child is symptomatically improving with your empirical antibiotic, and even if culture is something different, you have to continue with the same antibiotic until unless there is a clinical symptomatology failure. And I think most of the other things have been covered, and there are few questions, some I have tried to answer. And about one thing more I would like to say, antibiotic asymptomatic bacteriuria. Usually we never treat asymptomatic bacteriuria, but in certain conditions, like if they need instrumentation, like we need to have any procedure, in those cases even asymptomatic bacteriuria needs to be treated. So I think I'll come to the question and answer. Many I have answered.
Ma'am, can I ask a question?
Yes.
Many children mothers complain that the child is using the toilet again and again, but on urine routine and culture again and again, you don't find anything. And even the ultrasound findings are not much suggestive. So is it some kind of chemical cystitis or something, like they had been holding up, or it can be due to constipation sometimes?
So in that case, I would say as I said, we have to take a complete voiding history details of the child. One thing is, constipation is a very important risk factors for these children, and if we ask them number of voids and volume of the void, so in that manner, voiding diary comes in very handy. So if we ask them that if you are saying that your child is passing multiple times urine, let us document it for maybe 2 days or more. And in that case, when we find there are multiple conditions, we can pick up only by the voiding diary. Sometimes there are very small frequent voids only in the daytime, and the nighttime is completely dry. The condition which we commonly call as polyuria. So that is the behavioral problem in the child. So many of the answers will be answered if we ask the child or the parent to document the voiding diary for 2 days or more. I think that is what, and most of the time, actually, it's not a UTI. It is just the behavioral problem. Dr. Subrita, anything to add on to it?
If the child keeps on holding the urine in the school time and takes a very long time using the washroom, so can that lead to some problems?
Yes.
Constipation, definitely, like Dr. Ajay, you have mentioned and we have talked about, that is a risk factor for UTI. That also, even if it is not UTI, that means urine REMA and culture are normal. But constipation can lead to these urinary symptoms of urgency, frequency, and like Dr. Shobha is trying to explain, that you will see the child is voiding 15-20 times and all the time small voids. So that is only a frequency. But it is to, the parents get very concerned. So I like to ask them that, is the child also doing this at night? Is the child bedwetting or waking up at night to go to use the washroom so many times? So usually it is not so. Till that in toilet trained children, when it is called extraordinary daytime frequency, that they are only running to the washroom in the day whenever they have this kind of urgency, but at night they are sleeping peacefully. So that may be because of constipation. What you mentioned earlier, chemical cystitis, can be important in some children, because some mothers, we have so many TV advertisements, so they start washing the perineum also and vaginal area with Dettol, or some kind of medicated soaps. So that can actually lead to vaginitis, and the child feels that she is getting dysuria, more common in girls. So all that kind of thing, or washing the perineum even in boys with any and with these medicated soaps or antiseptics is not recommended. So that can actually sometimes lead to a chemical kind of cystitis.
Thank you.
I want to ask one thing. Many times, what actually happens that two different bugs. Like last week, he got the E. coli, and next week he got the Klebsiella. So, and with complete drug patterns. So, how to treat in these cases?
That is
Dr.
very
Shobha wants to answer this.
Yeah. As sir, I told sir, if you have started, suppose you have a child is symptomatic, you have sent the culture, and you have started empirically some antibiotic, and child is improving. So it doesn't matter if the and moreover, why would we ask? I mean, for request for repeat urinary culture if there is a improvement, even it is E. coli or I mean something which is improving, the symptoms are improving, we would not change the antibiotic whether there is Klebsiella or any other organism subsequently coming. Although we never actually, once we have started treatment, we never ask for the repeat urine culture. If the child is getting improved, even that course of antibiotic has to be completed, and we usually never ask for the repeat urine culture unless there is no improvement.
Yeah, so if there is no improvement, just to complete this, in a very sick child with sepsis, only then, and you are considering IV, like upgrading to another IV, like let's say ceftriaxone, you are upgrading the antibiotic to meropenem or something for urosepsis, only then before upgrading, you would send a urine culture again. But same, treat the child, not the report. No requirement for repeat urine cultures. Just if the child is getting better with the first line empirical antibiotic therapy, you do not need to repeat culture or change antibiotics.
And in very young neonates, where the UTI is suspected, it's very difficult to, female particularly, female neonates, very difficult to. So, is every time the suprapubic aspiration is recommended in very,
catheterized,
or
so we can take.
because catheterization is also not possible
No
sometimes.
feeding tube, I think under strict asepsis, you can just introduce a small feeding tube, take the sample and send it, and remove the feeding tube. That we can do. Or like, it was shown that quick V method, that you try to stimulate the baby's suprapubic area with some ice pack. Usually mothers are able to do that and collect a sample. But if baby is sick, then catheterized sample or a suprapubic is rarely required. But asepsis is important.
Sir, sometimes I would really like to add about constipation. Lot of times we can't do X-ray, we can't do ultrasound, rectal diameter, difficult to interpret by radiologist. One thing which is very easy to be done in OPD is a per rectal examination, because that can really tell you that feculates are there or not. And these children, especially children who have overactive bladder, like Dr. Ajay was asking, increased frequency of urine, you would not find anything in the urine culture and routine is sterile, but once you do a per rectal examination, you would find lot of feculates sitting there. So these are the children who are the candidates. You should give them enema, you should give them good amount of laxatives, and they really improve. And if they don't improve even after that, you can actually add some bladder relaxants, maybe something like oxybutynin, and psychological counseling like Dr. Shobha has said. That is most important.
There is a question in the chat box also, that if a small child and ultrasound is normal, but there is a 2 UTI. So what should we do next? Dr. Suprita, you would like to answer? So there is a 13-month child. It's okay. Uh, I will answer to this. Dr. Suprita, you would
Yeah,
like?
yeah, please, yes.
It's a 13-month-old baby and has had 2 UTIs, but ultrasound done in this baby has come normal. What would you suggest next imaging modality?
So first is that have we confirmed the UTI? So it's a young baby. I hope that it is not just a febrile episode with culture not being positive. So if it is culture positive, then only it qualifies for a recurrent UTI in a 13-month. If the ultrasound has been done carefully by an expert, has seen all the parameters, the kidney sizes, the ureteric dilatation, the bladder wall thickness, and even post-void residue, then we can be reasonably sure that a VUR or a PUV is not missed. But for in a male infant, we are always worried that we have missed out a posterior urethral valve that has led to this recurrent UTI. So go back to history to rule out any dribbling of urine, or sometimes the pediatric surgeons ask the patients to make a video of the urine stream. So I think that is helpful that we ask the mother that is the baby always in diaper? Please look at the urine stream carefully. As far as imaging goes, this child definitely requires a DMSA 4 to 6 months later. And also child is less than 2 years. He's had UTI twice. The guidelines also recommend that MCU should be done in these children after the completion of antibiotics for UTI.
So to summarize, in any recurrent UTI, all the three investigations has to be done. So recurrent UTI means you have more than one confirmed case of culture positive UTI. In that case, after completion of the antibiotic, initially we have to do UMCU to detect any significant VUR, and subsequently after 4 to 6 months we have to do DMSA also.
Thank you very much. I would like to thank both our speaker and expert for such a wonderful session today. Thank you, Dr. Shobha ma'am and Dr. SUPRITA ma'am. And now I would like to hand over the mic to Dinesh sir. Sir, are you there?
Sir. Thank you, ma'am. Thank you so much. Actually, I'm traveling to Punjab, Patiala. I'm in bus right now, so I've joined it. And it's a wonderful session. UTI is a never-ending topic, and even queries are never-ending. Wonderfully covered by Dr. Suprita ma'am. And this whole 12 sessions of eNephro classes were wonderful. Most of the topics are covered. Excellent faculty, well coordinated, and all kudos to the all faculty and our Dr. Neha Bhandari. And we are coming with a new module, e-metodology fix 9 to 10. So, and it's a good learning. So, it's a great learning process, e-module. Now, I would like to take from first Dr. Ajay Gupta, sir.
Thank you, Dr. Dinesh.
Yes, sir.
Thank you, Dr. Dinesh. Today's session was really wonderful because UTI is one of the most common clinical condition that we encounter in our OPD, and we have so many queries because parents also have so many queries, sometimes with difficulty in capturing the sample also. But you clarified most of the things. Thank you very much. Dr. Shobha Sharma is again great. And kudos to Dr. Neha Bhandari, who had been working for last 3 months very diligently on all the topics and solving all the queries. IIP Delhi is at forefront of learning modules. We have been doing many modules. We have already done on hematology, dermatology, cardiology, intensive care, endocrinology, neonatology. And we did a PCNI in June. We will be starting with master classes in hematology shortly, and link will be shared with all of you. We are also doing one CPR day training for police personnel on this Tuesday, 21st of July at 14 different locations. We'll be training around 15,000 police personnel on basic life support and the CPR. So I request any of you to please volunteer for the same. You can give your names to Dr. Neha or to us, and we'll be grateful for that. So thank you, Dr. Neha, once again, and thank you, Dr. Suprita and Dr. Shobha for today's session. Back to Dr. Dinesh.
Thank you, sir. Now, Dr. Lalit Mindra is also with us. Is our past president IIP Delhi. Sir, आप कुछ कहना चाहेंगे? Are you there, Dr. Lalit sir?
Hello.
Yes, sir.
Hello. Very nice session on UTI. Very nice session.
To see you on screen.
Very nice session on UTI. Really very well covered. Thank you very much. Very nice. No questions. Absolutely on the dot. Thank you.
Thank you, sir. Thank you so much. Dr. Ravinder, थोड़ा बहुत लगता है breakfast कर रहे हैं. Our treasurer cum secretary elect is also there. I welcome you, sir. And now I request you to please give vote of thanks for this session and the whole 12 sessions e-module of nephro classes. Over to
And
you, sir.
one more thing, certificates will be shared on email at the earliest in this week only.
Thank you, Dr. Dinesh, and thank you, Dr. Ajay, for a very thoughtful this e-learning. थैंक यू डॉक्टर नेहा। और आपने सही कहा डॉक्टर दिनेश, मैं नाश्ता कर रहा था क्योंकि मैं डॉक्टर नेहा भंडारी से इंस्पायर हो गया। उन्होंने अभी गिलास में लेके जब अपना कुछ लिया तो मुझे लगा कि मैं भी शुरू कर दूं। सो इट्स अ मॉर्निंग टाइम। So thank you, Neha, for revising our knowledge of nephrology. And thank you over both the expert, Dr. Shobha and Dr. Suprita. UTI is, yes, definitely a very important topic because it's pretty common. And couple of times, yes, somehow the the algorithm is not followed. जो आप बता रहे हैं ना recurrent UTI में, all these three investigations should be done. But we are many a times what we have seen, I get in because I'm in a government hospital. What I'm getting, they are treating absolutely nicely. They are giving the proper treatment. But all three investigations are not being done. VUR has been missed. Then patient comes again and again. And even in first episode of UTI, what has to be done. And these guidelines keeps on changing. I still remember earlier it used to be less than 1 year, 1 to 5 years, more than 5 years, then less than 2 years, 2 to 5 years, more than 5 years. So thank you all for clearing all these doubts. और ललित सर तो आजकल काफी अटेंटेटिव डेलीगेट्स हो गए हैं।
It is a privilege to be a delegate, to sit on the other side as a student, because you can always ask anything. You can clear your doubt. Nobody
Sir
makes
is
a
very,
stone
very
you.
keen to learn and every time,
So
and
better
he
to
is
be a
always
student.
available in most of the modules.
So better to be on the student side. You can always ask any question and nobody will scold you.
Yeah, very true. And it's always inspiring when you have such a senior person and कि उन्हें सब कुछ पता है क्योंकि वो पिछले 40 साल से ट्रीट कर रहे हैं। नेहा और हम जितने सालों से पढ़ नहीं रहे उससे ज्यादा से डॉक्टर ललित जो है वो यूटीआई ट्रीट कर रहे हैं, बट स्टिल ही हैज अ पैशन टू लर्न कि भाई न्यू डेवलपमेंट क्या है। So thank you and
it's always a privilege to be in the morning breakfast. जो class होती है ना morning की Sunday की, so I am always there unless I am stuck somewhere. So फिर मैं वो recording देख लेता हूँ। Very nice.
बस एक ही दिक्कत आती है जब सर कोई ब्रेकफास्ट करते देख लेता है तो थोड़ा सा वो लगता है खराब। एंड थैंक यू ऑल द डेलीगेट्स जिन्होंने पिछले 3 महीनों से जो लगातार अटेंड कर रहे हैं। आई थिंक दे लिटरली डिजर्व ए बिग सैल्यूट टू ऑल ऑफ देम। दे आर द पैशनेट लर्नर और ये उन्हीं की वजह से जो भी है वो सक्सेस है। थैंक यू अगेन नेहा। वैसे तो हम पिछले 3 महीनों में आपको हर संडे पे थैंक यू कहते हैं, तो मेरे ख्याल से यू हैव लॉट्स ऑफ थैंक यू प्रेजेंटली, बट स्टिल अगेन ए वेरी बिग थैंक यू टू यू।
IIP दिल्ली आपको सबको डॉक्टर ललित को such wonderful opportunity because these 12 weeks have been a great learner for me too. So thank you so much.
Thank you all. Thank you.
One message to the delegate. Many are asking when the hematology module is coming up. So we will post the link and the message about the hematology module very soon, and all can join again in the hematology module. So nothing to worry. And regarding the questions of the nephro session, so anyone can post in the nephro delegate group, and whatever we can answer in the group, right? So I think with this we are ending this module. I think once again we can say Jai Hind, Jai Bharat, long live IAP, and everyone a good day. Enjoy your Sunday. Now we are leaving you.
Join us on Tuesday. Join us on Tuesday.
अपना Sunday enjoy कर सकते हो।
दिनेश जी जय अजय, जय दिनेश, जय रविंदर।
सर आप लोग की जय है, मैं कहता हूँ हर IAP मेंबर की जय है और हिंदुस्तान की जय है।
We have only one request. We have only one request. Please join in the physical programs also.
Yes, definitely. And thank you, ma'am. Thank you, Dr. Shobna. Thank you, Dr. Suprita.
Okay.
Thank you, Dr. Neha. And it's from my heart, and we are very, very thankful to you. Bye. Good day.
Bye.
Thank you, delegates.
Thank you.
Thank you.
Thank you, everyone.